Hello and welcome to another informative Connectionology webinar. Thank you so much for joining us today. Your host, as always, Executive Director of Connectionology, Ginger Jarrett.
Hi, everybody. Oh my gosh, welcome. Thank you so much for joining us today. We have a wonderful webinar planned for you, and we're so excited to have Mindy and Jan join us. They have created an incredible presentation for you, so I'm very excited to have them with us today. Now, if you have any questions, make sure that you write them at the bottom of your screen. There's a Q&A box because we will try to ask some of them throughout the presentation, but we will save the majority of the questions for the very end to allow enough time to get through everything. But I want to thank everybody again for watching today. If you get a chance, be sure to go to connectionology.com because I've started adding more webinars to our website. So be sure to sign up and share with all of your colleagues. We definitely appreciate that. And I see Mr. John Romano has joined us. Hello, John. I am so
There we go. Hello there. How are you?
We are going to have a great day today. Now, for those of you who do not know, John is a nationally renowned trial lawyer with the Romano Law Group in West Palm Beach, which is a nationwide practice. And he's also a fellow of the International Academy of Trial Lawyers. And he's also served as a past president of the Florida Justice Association, the National Trial Lawyers Association, the Melvin Belli Society, and also the Southern Trial Lawyers Association. He's authored 3 books on discovery and advocacy, and he's also the editor and the co-author of AAJ's Anatomy of a Personal Injury Lawsuit, which is the 4th edition. And be sure to go check that out in case you guys would like to read a copy. He's also in the Trial Lawyers Hall of Fame, and both John is married to the most beautiful woman. Her name is Nancy Romano. They have 4 children and 11 grandchildren. So, John, very excited to have you with us today, and we can't wait to hear what Mindy and Jan have in store for us.
Thank you, Ginger, and that was wonderful. Thank you for those kind words, and thank you again for the work you do, the effort you put forth, for your amazing and beautiful attitude. And everybody that we run into talks about you and how uplifting you are, and it's just wonderful to have you start off these programs. But thank you for all of that work that you're doing to get all these programs ready. And I am very excited today. You know, if you look at the polling data and the survey data about credibility among individuals in different professions, it's not just an accident or happenstance or a coincidence that at the top are nurses. And the reason is we think of nurses as not only the medical health care provider that really has the more hands-on with patients, more so than anyone else. But nurses seem to us to be the protectorate of the people, the population on planet Earth. And that is just part of the reasoning why we have such great respect and admiration for nurses. In recent years, though, what I've found is that nurses, legal nurse consultants, are playing a far greater role in what we do as trial lawyers, as paralegals, as legal assistants in the practice of law. Very, very important because the role has changed. And we see nurses doing not what nurses were doing years ago, where it was limited for the most part to reviewing cases and records and organizing records, plus pointing out issues in cases. We're finding nurses now are brought in for every aspect of the handling of personal injury and wrongful death cases. Some of the things that we found in our practice, especially in working with the folks at OnPoint, are not just medical chronologies, not just reviewing and assessing and evaluating the medical records, but sitting down with the client and with key witnesses to do what I call a nursing legal interview, which is way different from the way a lawyer approaches the interview of his or her client. It's done with a different attitude. It's done with a different approach. It's done with a different set of goals in mind. So with that, I'm just so excited about where we're going with our program today. Two extraordinary presenters. I'll introduce first to you Mindy Cohen, who is with OnPoint Legal Nurse Consulting. That is a company out of Wynnewood, Pennsylvania. Our firm has worked with them for several years now. We continue to work with them, but I'll tell you a little bit about her. She earned her BSN and MSN degrees with honors from the University of Pennsylvania, one of the more extraordinary universities in our country. She held consulting positions developing healthcare programs, and that led her to be a nurse manager in a nurse management position in a rehabilitation hospital involving business development and marketing aspects for that business. She then joined the American Association for Legal Nurse Consultants. Eventually, her peers elected her to take on the presidency of that organization. So Mindy is the former president of the American Association for Legal Nurse Consultants. She is a certified and credentialed legal nurse consultant. To be certified or licensed by this organization, so that you know, it's not just a matter of getting the certification. You go through a rigorous process and the application process. Then you go through interviews. Then you have to take a rigorous test. Then you have to have all kinds of experience requirements. So it is a rigorous program to be evaluated, and that's how she became certified. If you talk to Mindy, what she will tell you, though, is that her whole life she wanted to be involved in something that she calls Perry Mason-like, where there was investigation involved, where there was cross-examination, where there was trying to figure out what is the answer to the puzzle. And that's what she does. And that's why she's not only a fabulous nurse, but a really spectacular legal nurse consultant. Speaking along with Mindy and presenting today is Janet Dolan, registered nurse and a certified nurse life care planner. Jan was in practice for 25 years in critical care and cardiac nursing. And then at some point after that entered the medical legal arena and began her work as an in-house legal nurse consultant. She now does all sorts of things, including in her own business, nurse consulting business since 2014, specializing in nurse life care planning and medical cost projections. And when you think of what we are doing now in personal injury and wrongful death cases, you think of the medical costs, you think of life care planning, especially in the catastrophic injury cases. So it is an honor for us and a real privilege to have these two wonderful women, wonderful nurses, wonderful experts in Mindy and Jan. I will turn the floor over to you. Take it away. There we go.
Yeah. Thank you, John, so much. That was quite an introduction. Hello, everybody. It's our pleasure to be here today. Jan has worked with us for many years on our life care plans and medical cost projections, and I'm really thrilled that she could be here to share her expertise as we talk about the damages of your cases and what we can do to help you maximize those. So we're going to talk today about not only the physical injuries and damages that your clients have, but those that are not readily apparent. The pain, the anxiety, the depression, the fears, and then we're going to try and show you examples of how we go through the record and how we demonstrate that for adjusters and juries and what have you, and then how to capture all of the economic pieces to maximize getting all of that in. So we're really excited to show you this holistic picture today of this whole scope of damages, economic and non-economic. So we use 3 different strategies at OnPoint, and some of them, like the chronology and analysis, are probably familiar to most of you. And let me just minimize this picture for myself. And then the pain and suffering report might be something new. So we're going to talk about each of these strategies and how we bring them to bear for your case. We want to help you lay the foundation for the specific damages that your client has suffered. And we want to make sure that you are not blindsided by anything in the medical record. So the first thing we're going to look at is key records in the record to help you lay out your case and rebut any defenses that are necessary. So we're going to go through all of the significant unrelenting back pain that your client has gone through. What was non-responsive to conservative treatment? Where were injections? All the way through surgery, post-operative PT. So whatever that range is, we're going to be able to show that to you in a variety of different ways. The chronology and the pain and suffering report can really be helpful to prepare your client for testimony. So we can look at the before and after picture. We can use that to remind your client all of the failed treatments, all of the frustration and the pain, and helping them to bring that experience back to life during their deposition and testimony at trial, if need be, as a way of not forgetting what that was like as they were going through it. And then the analysis will cover missing records. Do you have that prior MRI to compare to the current one for the purposes of looking for what is new or what is aggravated that may have existed before? With strengths and weaknesses, we'll look at causation and prognosis statements. Are there inconsistencies in the record that you need to deal with? And if you have a med mal case, then we can look for potential defendants that are going to be important to address with the types of experts you need. So also, you know that attention to detail wins cases. So when we're going through the medical record, either for the purpose of a chronology or a pain and suffering report, we're going to be looking for some red flags, things that you need to know about so you know how to manage the case, you know where you need to go next. And I just wanted to bring up a couple examples for you. So for instance, we see this a lot where PTSD diagnosis will be somewhere in the record. And maybe it was by a primary care provider or an orthopedic doctor. But there's never any ongoing documentation of it. There's no psychiatric eval. There's no ongoing counseling. It may never even be mentioned after the first couple pieces of documentation in the record. So it's really important if you want to make something, if your client is really suffering flashbacks or other PTSD symptoms, that you want to have an official diagnosis and ongoing treatment so that we can capture it and you can capture it in presenting that to the opposing counsel and so forth. Similarly, with a TBI diagnosis, oftentimes without a neuropsych assessment and a treatment plan, the adjusters will just kick this out. So there's a whole debate about neuropsych and what have you. I don't want to get into that here, but I will say that we've heard from adjusters and things that we know about Colossus and other insurance software programs. You need to have the neuropsych assessment and that documentation to build that element of your case. Repeated treatment. So we see this a lot too, and you should be aware of it. If you have a client that's in physical therapy for months and months and months, you want to make sure those records are demonstrating improvement. if they're just going and you're running up bills for treatment, but there's really, your client has plateaued and there's no improvement, it's going to be challenged by the defense. So you want to look at both repeated treatments and what might be considered repetitive treatment. So if your client is seeing PT, chiro, massage, acupuncture, all at the same time, those modalities might be questioned either in a bill review or just in the necessity of treatment, because it's unusual for you to have so many different modalities at the same time. Gaps in treatment, missed appointments, these can be rather easily explained if your client can't get off of work or they're out of town for a funeral. But on the other hand, if it's they're just not compliant, or they're not going, or they're not working hard in physical therapy, that can come back to bite you a little bit. So you want to know that this is in the chart because you're going to likely see that out of the defense. So you want to be prepared for it. I think we mentioned missing records again. If there's a provider, a referral to Dr. Smith, a neurologist, was documented in the record, but we don't have Dr. Smith's records, we can let you know that. I talked about the causation and prognosis statements, and I have an example of one that I'm going to show you later. So we look for key findings in the record that will help support your case. And the same thing on pre-existing conditions. Was your client, everybody at my age at least has back problems, right? So if I'm in an auto accident, when was my back last symptomatic? When was I treated for it? Maybe never, maybe last month. So we want to always look at what was your client's status at the time of their accident and just before. And I have a great example I'm going to show you about that later. So if we move into the realm of pain and suffering, it's very difficult to understand. We know that Margot McCaffrey did some of the very early work in defining pain, and especially in the nursing arena. And she says that pain is whatever you are experiencing, whatever the person says it is, existing when they say it is, because it's subjective. No two people are going to feel pain in the same way over the same event. So I've been giving COVID injections. I've been volunteering as a vaccinator, and I have people that come in easy peasy. They, open up their arm, inject them, done. And I had another woman whose anxiety was so severe that she had to take 2 Valium, and her husband had to get a companion pass to bring her in because her fear of needles and her pain associated with it, her mental pain, was ridiculous. So pain is a very tricky thing. And as we're going to see, we know that pain, I like to call it multimodal. It's sensory, it's motor, it's emotional. It is potentiated with stress and anxiety. And stress and anxiety potentiate pain, pain potentiates stress and anxiety. So we've learned a lot that it's not just the physical pain from fracturing a leg, it's everything that goes into it. It's our ability to walk, it's our sensation of pain. It might be how tight the cast is. It might be how our function is impacted by the pain. So our view of pain has really become quite broad. And as such, the treatment of pain, we have to look at as multimodal as well. It's not just about narcotics anymore. So I remember many years ago, as John told you, I'm doing this for more than 25 years. And we used to, count up how many milligrams of morphine. And if somebody wasn't on narcotics, we were like, oh my God, they're not injured that badly. But now we see it's steroids, it's antidepressants, it's treating the complications of pain. So somebody's maybe getting narcotics and they're immobile, and now they need a whole bowel regimen to manage their constipation. They have to take fiber, they have to take a stool softener, maybe they need an enema. So all of those things are part of the pain picture that we may not have associated with pain in the past. Now, suffering's a little interesting as well, fascinating to me, because it's really a psychological concept of loss, an actual or perceived threat to oneself. And it's a little bit harder to get at, and sometimes we find this in the medical record, and sometimes we have to dig a little deeper. So I found some psych records in one case, and I thought this was a perfect explanation of suffering. So I want to share it with you. A woman was describing how she had a very bad back following a motor vehicle crash. And she said that when her back acts up, she has to rely on her family members. They have to drive her places. They have to do her housework. She can't get down on the floor to play with her grandchildren. She can't babysit for her grandchildren. And then she gets so worked up into being so depressed over all of that, that she then begins to increase her activity. Her activity increases and increases till she feels better about herself. And then what happens? Her back goes out. She's doing too much. And then she has to revert back to that level of dependence on others and loss of independence and loss of self-control. So it is an awful cycle. And I'm sure that cycle sounds familiar to many of you, because oftentimes for clients, it's hard to find that right balance. And that's just a great example of suffering. So as we move along, we're going to see that when you look at pain and suffering together, you're really impacting every element of somebody's being. Their physical, their physiological, their functional. How do they get around every day? Can they do what they used to do? Their mental outlook, and then all of their other activities of daily living. How they care for themselves, how social they can be. Are they isolated? Can they still get to church or synagogue or whatever their religious affiliation is? Have they lost their job? Are they in a financial situation? So we have to really take the broadest view again about pain and suffering as part of your damage picture. So now I want to talk to you about this pain and suffering report. And we call it different things. Sometimes it's called a patient care report, a plaintiff care report. Sometimes it's called a 1006 report based on the federal rules of evidence, which I'm going to touch on in a little bit. But essentially, there are a couple important key things about the pain and suffering report. It tells your client's story chronologically from their time of injury in layman's terms. So it talks about your client's injury and then the care they received because of that injury. It's very fact-based. It is not opinion-based. So the care, such as in this example, what's it like to be on a ventilator? We'll explain it in the report, and then we'll show some illustrations as a point of education. So we take some of these types of pictures off of the internet. However, we'll talk about this. This is for education only. So when you go into mediation or court, then they need to be authenticated and we go a different route. But in essence, what you have here is somebody who's on a ventilator, and we're explaining what's it like to be suctioned every hour. What's it like to have that catheter blocking your airway, perhaps triggering a gag reflex at the back of the throat. It's really powerful. If you're talking about somebody with sciatica and radicular pain, what better way to describe it and then show an image of how that pain travels down the leg. So that's the essence of the report. The report is shows the good and the bad. So if your client's having a good day and we're doing a pain chart that's, at 1 out of 10 or how many out of 10, we're going to document those days where it's only 3 out of 10 instead of 10 out of 10. So you're really trying to show what happened to your client over time and present that story. So we will go chronologically through your client's care and go through this. At the end of the report, we'll have various charts, and I just brought a couple to this presentation so I can show you. This problem list, as we call it, is a really great summation because you go from looking at this client story chronologically, and then you're going to pull out all of the different areas, as we talked about before, the physical, the physiological, the psychological, and there are other pages by the problem, by the damage, if you will. So in this case, we had a fractured leg, and there was an asthma issue that got worsened, needed a ventilator because of it, urinary tract infections, through to depression. And this is a case we'll come back to. On the fears, what I want to show you is this, when we were reading the record in this case, this plaintiff was, you would think she was the devil herself, yelling at the nurses, foul language, nobody could reach her. And they finally brought in a chaplain who, over the course of some days, really began to understand that she was in a wheelchair and had MS and was hit by, and lived independently, significant injuries after being hit by a bus. And what was at the root of everything was her fear of institutionalization, and that she was not going to be able to go back and live independently in her group home. And it changed the whole flavor of the case. So it really takes paying attention and actually looking for those details to try to describe the impact of pain and suffering. So in this case, this first quote is something we used at her trial. She had been in a bed immobile for 8 months. So she had never had a shower. She had a bed bath for 8 months. So just the idea of that is quite powerful. So we're going to be looking for significant findings and comments in the record. In this next one, this is another case of with a causation statement, dementia secondary to traumatic brain injury with a date beginning 10/22/17, which matches the date of the motor vehicle crash. And here you have some information about the head injury. So it's really trying to look for those gems in the medical record that are going to have a big impact in explaining the injuries that your client has suffered. This chart, I always love this one. Whoops, hold on. How'd that happen? So this chart, we really wrestled for a long, oh, I apologize. We seem to have, I don't know why that's going automatically, but this is a functional ability chart. And what we do is we try to go through and identify all of the activities of daily living. I apologize for this. Bathing, grooming, dressing, ambulation. And then we'll take snippets of time. Where were they prior to the, yikes, I'm so sorry. Where were they at the time of the injury, independent? And then how much back to baseline do they get? So in this case, you can see that bathing needed minimal assistance, so not back to full independence, but yet dressing, they were fully independent. I apologize for that. So anyway, there are ways to go through the chart and capture where your client is, because on the functional recovery, it's very easy to just say, oh, my client was laid up for 10 months And then they, sort of got back to walking. But the problem is that 10 months was probably very hard and tedious work to get back to some level of baseline. Some things in the chart are really interesting that pop out to us. And we always look to see, what can we quantify? Can we show how many providers, how many days in the hospital, how many invasive procedures, the variety of medications? So you could see here, pain, spasms, anxiety to prevent ulcers, and then sleep aids. So we think this is a really impactful way of demonstrating what it took to bring your clients' injuries into focus and to treat them. Now, of course, there's going to be a defense perspective. And usually we know that the defense is going to want to verify all of the plaintiff claims. They're going to want to expose any exaggerations or contradictions in the record. So we're looking for them to make sure that, again, you're not blindsided and you're the most prepared attorney in the room. The defense is going to want to focus on what the plaintiff can do, not where they've come from, not so much the before and after picture, but can somebody with burned hands still open their drawers? Do they need a new kitchen, or do they just need new handles to be able to use the drawers and cookware that they have? So they're going to be focused only on where the plaintiff, what they can do. And then, of course, they're going to have their defense medical exam, which will look for alternative theories for pain and suffering, alternative causation. And we've seen several cases where there's been divorce, there have been deaths, all in the same time period that your client's recovering from the injuries as a result of their lawsuit. So differentiating them and trying to understand what you need to do and how your experts might need to approach that is going to be important. Now, I have a couple sample timelines. This was a case that we did many, many years ago. A client fell in the street over a broken manhole, and the attorney was told that he developed a varicocele and a fractured wrist, and what looked like a really strong case to the attorney. And so once we looked at the medical records, we realized that maybe it wasn't as strong as the attorney thought. So there was a very time-limited injury with the groin pain. It turned out that the varicocele was an incidental finding, probably something he was born with and not trauma related. And there was never really any follow-up from it. So 3 months from the fall to the date of ultrasound, and then we never saw back from him again. So not the strongest piece. And then when we looked at the wrist fracture, he's doing pretty good for the first 5 months. He has fixation at the fracture site. But after that, all of these red boxes are all evidence of non-compliance, refusing to wear the splint, refuse the cast that was in two. He had a electrical stimulator, wasn't wearing that, refused surgery despite being told he would have permanent injury. So it was a really challenging case. This one, we went to arbitration on this one, and there was a $70,000 award, but a 40% contributory negligence. So it's important to know what's in the record and how to position yourself and your client for the potential outcomes. So there are a few different ways to use a pain and suffering report. One, if it's a really significant case, it's pretty good for forcing a pre-suit settlement. And that's because there is no arguing with it. It's a fact-based case. There are no opinions. There is only explanation of voluminous and complex medical conditions. It is not about whether the care is good for your client. It is not about whether the care was appropriate. It's what it was and what was the impact on your client. The next, we talked a little bit before to help prep your client for testimony. So in one case, we saw a PT note where the client said, I don't know what's the use of these exercises. I'll never be able to walk again. And, you know, helping remind your client that he once said that and what was it like in that moment to realize that you're going to not walk again. And you're going to PT and they're making you do exercises that are probably painful, and you'll be lucky if you can walk with, you know, 20 feet in the future. So trying to understand that and really prep your clients is really going to be important. Creating a settlement package. I'm going to show you some examples of some charts and illustrations that we've done for settlement packages. And then the foundation for testimony, whether a nurse is testifying for your client to lay this foundation of their care, or if it's the testimony is by somebody else. Okay. So these are a few charts that I wanted to share with you from some different cases that are different ways to show pain and suffering. So in this is a mesh case post a hysterectomy. And there was an infection in the mesh that went from the top of the vagina through the mesh to the sacrum. And when we were reading the op report, it just struck me how awful this sounded and what a great exhibit it would make. A large inverted V over the buttocks and down the left thigh. So we're talking about a large area. A large amount of myelonecrosis and the dead muscle was excised. Really significant to lose a part of the muscle of your butt due to infection. And then several large pus pockets deep in the gluteal muscles. So sometimes you find information in the record that is not just in a progress note, and you have to be open to that and recognize it for what it is. And then also in this case, it was important for us to demonstrate this wasn't just any surgery. This was so significant, this client had to go to the ICU for treatment after, post-operatively. This is a real interesting one. We work with MediVisuals, and they are also sponsors of Connectionology. If we need these kinds of charts, some of our attorneys like them. Some think it's a little bit too over the top and inflammatory. But in cases where there are multiple injuries and you want to make a big impact, you might choose something like this. Versus in another case, you might just have 3 small pictures. It's pretty simple, but it tells the story of a significant fracture, the placement of the rod and screws, and what that looks like. So again, it's taking what's inside the body, what actually happened to your client, and trying to find a way to make it visible and impactful to opposing counsel and the jury.
Hey, Mindy?
Yeah.
I was going to pop in just for a minute, and we're going to take just a short break so I can introduce.
Let me stop sharing right here.
Thank you so much.
Yes.
You're doing such a great job. I'm actually getting messages behind the scenes of how good this is. So thank you to everybody who's watching. I'm really happy to hear the feedback. But it's my pleasure. I want to go ahead and introduce Kyle Kinberger with HMR. And you guys, if you don't know Kyle, you need to get to know him because he is wonderful. And the work that they do for clients all over the country is really amazing. Kyle's going to tell you a little bit more about what they offer. And then also at the end of the webinar, he's going to join us again because somebody's going to win 4 bags of this fresh roasted coffee. And it could be you. So we'll see. So Kyle, thanks for joining us today.
Yeah, no, it's good to see you again. Hey, Mindy, it's good to see you too.
Hey, Kyle.
Yeah, so as I think as a lot of the attendees know, what we specialize in is assisting plaintiffs when they are injured, but they don't have health insurance to get the medical treatment that they need at the time that they're injured. So a lot of cases we run into are people who even have things like Medicare, Medicaid, but it's just not enough to get what they need. So a lot of the uninsured and underinsured cases is really where we step in. Most of the stuff that we tend to do is catastrophic in nature. So we get a lot of calls from attorneys who have somebody who's got a brain injury or an amputation or a severe spinal cord injury. And so I think the beauty of it is we're working with providers across the country right now to, allow patients to get those kind of treatments. And all of the stuff that we do is non-recourse. So we try to really partner and take the risk with law firms if there is one. I think in this business, you have to be timely. And I think that's one of the things we pride ourselves on, from the time we get a request to the time we actually can approve and get things going and get people the treatment they need has been a really strong point for us. So if we can do anything for anybody, we're absolutely here. We love being a part of Connectionology. It's such a great program, and we appreciate you having us week in and week out.
You all are terrific, and I can't thank you enough for helping to sponsor Connectionology Seminars of America and be with us all these months in the webinars. But we started working with HMR. It goes way back to, I want to say 2008 or somewhere in there, and it's been just terrific. And what I love is you all are so responsive. You also understand the business needs of what is happening in a case, what is happening in a law firm in order to make it happen in these cases. And as a result, it's just been wonderful. So again, just many, many thank yous.
You got it. Thanks, John. Thanks, Ginger.
And I'm also excited to announce that Kyla is going to be joining us again, and we're going to have Hugo Chinez, who's a great attorney out of New Orleans as well, on June 22nd. I'm actually working on getting that webinar added to our website, but they are going to be talking about how to use the discovery process to sideline the defense's TBI experts. So be sure to save that date. It's going to be good. Thank you, Kyle.
Thanks, Ginger.
And then now it is my absolute pleasure. For those who don't know Leon Branham, he is also wonderful. And we're so excited to be working with him as well. He's going to share a little bit about what he does at Fast Funds. They do great work. And Leon also works for a lot of people who know Bruce Braxton. You've probably seen him out and about at a lot of conventions, but you'll also see Leon as well because he's been doing this for like over 15 years. So, and I believe he's going to tell you a little bit more about how Fast Funds is like one of the original companies that started doing this way back in the day. So, Leon, thank you for joining us, and tell us a little bit more about what you do.
Sure. My pleasure, Ginger. Thanks for having us. I feel like the fourth wall is broken down because my virtual background doesn't work. So people know that I don't have a beautiful office anymore, just a green screen. But it's a pleasure to be connected with Connectionology, the great attorneys. Obviously, everyone knows John's a great guy, but it's a pleasure working with all your speakers. And Mindy has been a dear friend for many years. So, and gotten to work with many of your attendees. So this has just been a great experience all around. For those who aren't familiar, Fast Funds was one of the first, the original litigation funding companies that started the industry 25 years ago. We provide non-recourse attorney and plaintiff funding solutions on an individual case basis. So it's like a financial David versus Goliath, right? The plaintiff attorneys must cover their own expenses on every case upfront and on a contingent basis. And meanwhile, the defense has all their fees and expenses covered by deep-pocketed insurance companies. So this creates a culture where the defense delays case resolution and will attempt to outspend you as a tactic for your client to accept less than their case is worth. So what do attorneys do now in this unlevel playing field? Well, some attorneys will self-fund one case at a time, but you can only, you have several cases. What do you do with your other cases if your money's all tied up in one case? What about your overhead? What about your marketing? Some attorneys will refer their cases out, but when they do that and they don't cover the expenses, they're giving up 40 to 75% of their fee. Many attorneys will try to stretch their dollars with less expensive experts. But if you pay peanuts, you get monkeys, and good experts like Mindy and like Bob Shepard are worth their weight in gold. And many attorneys have tried to go to a bank, but a bank's a place that'll give you an umbrella when it's sunny outside, and they'll ask for it back when it rains. And that's a nice way of saying that they're regulated and they're unable to give you credit or value for your most important asset, which are your cases, because it's on a contingent basis. And unfortunately, sometimes you just have to live to fight another day and accept less and try to make it up on the next case. Well, there's a better way. At Fast Funds, we've developed a unique funding product for plaintiff attorneys to help cover expenses on individual cases on a non-recourse basis, which means there's no personal guarantee, there's no lien on your portfolio of cases or your attorney fees. So what that does is allow you to move more cases along now by engaging the right experts where they're needed the most. We've had, you decide what's best for your cases. We don't tell you who to use or, what your case needs. We're just here to kind of support you financially in your portfolio. And attorneys that have worked with us have had fantastic results. It's timely because we've done a lot of work for Mindy's attorneys or attorneys that use Mindy, where they wanted to not only use her services, but use her services on many cases at once so that they could get the benefit of increasing the value, proving the damages, and decreasing the time it's spent in litigation. So we'd love to do the same for the attendees here. And if there's anything we can do, or you just want to chat about a case, I'll put my contact information in the chat box. And thanks for allowing us to be of service.
Leon, I just want to tell you, I like the green screen. I thought you were trying to show us how creative you could be by being different and having a plain screen. But thank you, and thank Fast Funds for not only being a sponsor of Connectionology seminars, but for all you do for the legal profession. This is very, very important work. Getting funds to these clients, many of whom cannot keep their respective heads above water without having this type of funding available. But the great thing is that you all are very responsive. You understand the needs of the clients and you understand how cases move and the things that cause them to not move. So again, thank you for doing a great job, and thank you for being somebody who's always there for everybody in this profession. Thank you.
Thanks, John.
And one thing too that I love about Leon, John, is that if you have a question about anybody else in the industry, if you have a particular case that you're working on, Leon will probably know somebody who can help you. So he's a really great friend.
He will.
Yeah, very great friend to have. And I want to thank everybody who's been reaching out to me later on. I've been getting messages from our attendees saying, hey, what's the name of the guy from Fast Funds, or what's the name of the guy from HMR? And I just love that. I really appreciate that because you guys, when you work with the people that we work with, you're helping ensure that we can continue doing these webinars and seminars. And I love organizing these for all of you. And I just want to thank you. So doing a great job, Leon. Thank you.
Thanks, Ginger.
And last but not least, we have Connor. He's joining us with Strategic. He's fresh off of a plane from Cabo. I hate to say it, I'm a little jealous, but Connor, we're glad that you decided to leave so you could join us again and be with us this week. Thank you so much for being here. Tell us a little bit about Strategic for those watching who don't know anything yet.
Absolutely. It's great to see you, Ginger. John, it's great to see you as well. Cabo was amazing. You guys should check it out next year for sure. But here at Strategic for almost 20 years now, we have We've been identifying, and really more importantly, we've been connecting attorneys with ex-employees of their corporate defendants. And then we flip them into insider witnesses or whistleblowers. And it's a two-step process for us. And the first step is creating an actual list. We call it an EAL, an ex-employee list. And that's a unique product because it's specifically tailored to what would benefit you most. For example, if you only need janitors and assistant managers of Home Depots in Atlanta, Georgia, that worked there from 2013 to 2018, that's exactly what we're going to find you. It's very specific and it's very tailored to what you need. So once we source that actual list for you, then we can come in with our interviewers. We have 7 interviewers on staff that are very good at what they do. They get on the phone with these ex-employees and they start a relationship. They get them to be sympathetic towards your case and towards your client, and really just blow the lid off the case. I cannot stress the importance of ex-employees enough. These are individuals that have been there during that negligence. They know the day-to-day operations and they're willing to talk about it. So this is a redacted exemplar that I would love to share with anybody that's interested. This is specifically for a nursing home case, but we do all types of cases. We work with attorneys all across the country with big cases or small cases. It doesn't matter. So we also are able to identify class reps for class action lawsuits. And we can also run other similar incident reports as well. So if you're interested, my information will be in the chat below. Ginger, thank you so much again for having me on. And John, it's great to see you.
Hey, Connor, thank you so much. But I'm wondering how come we weren't invited to go down to Cabo? I've just passed that out as a thought. But hey, thank you for all you do. You know, many years ago when I first met Paul Luttrell and he told me about the work done at Strategic, I thought that's impossible. And then we hired you all on the first case and Paul just worked a miracle. And we then had it happen a second time. And you all do find people that nobody else can find. And as you say, you get them to come forth and they're whistleblowers and former disgruntled employees that seem to be off the grid, but you find them when others just cannot. So thank you for your work. And I really thank you all for doing everything you do to help us here at Connectionology Seminars of America. So great job and thank you. And we expect the invite next time you go to Cabo. Just a thought.
Okay, sounds good. Thanks, John.
Awesome. Thank you again, Connor, for being with us. And don't forget to write your information in the chat box for everybody, okay?
Absolutely. Good to see you guys.
You too. All right, now we're going to turn it back over to Mindy, and then Jan is going to be joining us and also in a few minutes, and they still have a lot of great information to cover. So thank you so much, and we look forward to seeing what's next.
Thank you, and thanks everybody. Yes, I will put in a plug for Leon as well because we do use fast funds for our clients to fund our services and our experts. So it's a great resource and we're happy, Leon and I are happy to discuss that with you. So these next 2 slides are 2 that I want to show you about before and after and trying to take the wind out of the defense's sails that yes, we're aware there might be a prior history. In this case, it was how much personal care was needed. This is from our case of the person in a wheelchair with MS. So you could see she needed some care, some assistance, personal assistance from a home health aide. But after her accident, quite a dramatic increase. It's really nice when the numbers can be turned into a graph, very impactful. And then another way to demonstrate that is on a timeline. So in this case, you can see a 5-year gap in care, same types of injuries, right shoulder, right knee, elbow, left knee, and back, but a 5-year period of asymptomatic, no complaints in the record that we could find, and no treatment until the time of this next accident. And then you could see how much more significant the care was. This is another kind of timeline of someone who was injured in a fall and needed 9 surgeries over the course of 2 years. And this is something really interesting. This was a survivor of a plane crash, but it could be any kind of a significant trucking accident or what have you. And each of these areas represent a major injury, traumatic brain injury, bone fractures. And then we did a review, a schematic of all of the sequelae that came as a result of the TBI, as a result of these fractures, et cetera. And then each of these areas can be broken down to show significant pages of the medical record. So if this is just then the attorney wanted an in your face, I want to just show how densely populated this chart is, because this is how densely injured my client was. We try to, when we're doing mediation presentations, we try to always do before and after pictures. So this is a very sad case of a woman who had dementia, mild, able to live at home. She was being transported to a doctor's appointment and her wheelchair was not locked into the van appropriately. The van was in an accident and she was thrown and she just never really recovered. She had 2 fractured legs and went downhill. And I couldn't show you the pre-pictures because they were pictures of her in every slide with her grandchildren and gardening and listening to music and playing the piano and everything she loved to do. And then this is the last 8 months of her life. It was really a powerful juxtaposition. And then this was just a very simple thing where she had this accident, she lost her mobility, she lost her independence because she never got out of rehab, basically lost her health, lost her home, and died. And as I mentioned, you know, if you're looking at testifying, then we can testify as a result of your pain and suffering report. And it really is going to depend on who tells your client's story. Is your client dead or alive? If they're dead, that's an easy one. If they're still alive, then you have to think about everything you think about as to whether they're going to make a good witness and if you want them to tell their own story. And as John mentioned about the value of legal nurse consultants, nurses are credible, they're very believable, they take the broadest possible picture of a holistic approach to patient care. And that really makes legal nurses a great tool for telling your client's story on an expert fact witness basis. And obviously you're going to have to deal with rules in your own jurisdiction, but as nurses, we are able to summarize voluminous and complex medical records. And as long as the person who did the summary is available to testify, we should be able to be admitted to testify. We have the background, we're qualified by our training and our experience to provide opinion or otherwise, so this would be otherwise. And the hearsay exception, we can overcome on the fact that we're using medical records that were contemporaneous with the event. And we're just explaining what they say. So it's a very exciting role, and clearly our information can support your experts that you already have on the case if you really can't bring in or don't have a need to bring in somebody as an expert fact witness. There are a few challenges to the testimony role that you're likely to see out of the defense. And one is, oh, well, they're not a doctor. What can they say? And again, because it's not opinion-based, it's factual, laying the foundation of what happened in the case. that should be an easy one to overcome. Use of the treating professionals, mostly it would be very unreasonable to bring in 8 testifying experts to lay the foundation of what happened in your client's story. So it's easy to overcome that. I'm going to tell a real quick story, but I want to let Jan get to hers next. One of my first testimonies on a pain and suffering report, the defense attorney had me read into the record every time the 3 appointments by the neurosurgeon that said, doing great, doing better, discharged, everything's fine. And he made the mistake of not knowing the difference between the neurosurgeon's role and the neurologist and the neuropsych's role in the treatment of a person with a brain injury. And when he asked me, well, if the neurosurgeon says everything's okay, if God says that this patient can be discharged, why was I here trying to explain that this patient really wasn't any better? And then we went and had this whole discussion about the fact that the neurosurgeon relieves pressure on the brain and their job is basically done. And it's everybody else that treats the client who's going to address all of the functional and emotional sequela from that brain injury. And that case settled pretty quickly after that. Okay, so I am going to turn it over to Jan. It's my pleasure to have Jan. She's been working with us for a long time, and she's really got a lot of experience in medical cost projections and life care plans. And Jan, take it away.
Sorry, just unmuted. Thank you. So basically, I'm going to talk about medical cost projections versus life care plans. What is your case? Switch me. Next slide. Basically, the cost projections versus the life care plan, we're looking at non-catastrophic versus catastrophic injuries. Are you looking at an injury or injuries that are sustained in an accident? They've been assessed, acutely treated, but your client is having ongoing issues relative to that injury. Basically, maybe a mild concussion, but they have lingering, ongoing symptoms, headaches or ringing in the ears. Neck or back pain, if they've had a spinal column injury, what are the ongoing issues associated with that? Did your client sustain a joint injury that acutely was treated, but there are still ongoing issues, and you have a physician saying it's very likely that down the road they're going to need a joint replacement? Or are you looking at other orthopedic injuries that have affected the full function of that area of the body, and you have a physician saying, very good chance that this patient's going to develop arthritis as they get older? Those are the more non-catastrophic issues that we're looking at that are clearly addressed in a medical cost projection. On the other hand, if you're dealing with a client who sustained an injury that basically is life-altering, their life will never be the same because of it. We're talking about injuries such as spinal cord injuries. There could be paralysis just below the waist, not just, but paralysis below the waist. Could be paralysis up to a point where they can breathe on their own. Could be paralysis where they are permanently on a ventilator, but they can blink their eyes in communication. They can use their eyes for a lot of the equipment that's being developed for those purposes. Are we talking about a traumatic brain injury where there is true alteration in that individual? Personality has completely changed. They have a decrease in executive function that's never going to return. They have a complete change in their ability to perform even their activities of daily living. They have to be either, challenged or say, it's time to put on your socks, it's time to brush your teeth, or can they do those things or maybe not do them at all? So there's a complete change in their living, in their ability to perform their activities. Are we talking about amputations, single, upper extremity, lower extremity, severe disfiguring burns, or cerebral palsy? So those are the five main catastrophic injuries that are generally addressed in life care plans. Next slide. So I'm not going to, you all know what medical cost projections are and what life care plans are, so I'm not going to tell you step by step how they're developed. But I want to point out a few, I think, key points in both, just to raise an awareness of some things that need to be looked at when you're asking for or searching for something to help you settle your case. In the medical cost projection, that basically is information gathered by you from the treating healthcare providers that actually there'll be a letter addressed to you, dear Attorney Smith. You know, I am treating your client, Mr. Joe Johns, for the following injuries. This is what the diagnosis is, and this is what I project he's going to need in the future. As you know, some treating physicians are very conservative in what they're willing to put in a letter to an attorney, or they're just not quite as aggressive as you think they could be in treating your client. So at that point, that's when you will go out and you'll get your independent medical examination. So it's either information from a treating physician or healthcare provider who is assertive and they really want to get this person, give them every chance there is, every modality there is to get them better. Or you need to go for an IME, so you get somebody that you've worked with that you know will be very thorough in that assessment. And so I take the information from those two types of letters or reports, as well as may ask for more current progress notes from the treating healthcare provider, because there may be updated information from the time that they sent you their letter. Put that all together based on my knowledge and experience and produce the medical cost projection. There is not as much input from me other than being able to add to what that physician has said they're going to need down the road. For instance, if they say, I suspect in 5 to 10 years they're going to need a joint replacement, or that hardware may need to come out of the ankle, then I know, with my nursing background, that's going to be followed by physical therapy. The doctor didn't point that out in your letter, but I certainly will point it out in the medical cost projection because it's all part of the package of his diagnosis and treatment. Next slide. Next slide. These are just samples of what we just talked about. We have letters specifically to an attorney saying this is what happened to the individual at this time treating. The other one is just a sample, obviously redacted, of a visit note that I think that when I say to you, it appears this client may have had more visits from when this letter was written. Can you check to see if there are any office visits notes? It can often get information on that that's very pertinent to the outcome of the cost projection. Next slide. When I take that information, when you get a medical cost projection from me, you get two formats. The initial page is a summary, or it's a narrative in which only the points are presented. I don't go back and recount all the physical medicine that has taken place. Your doctors have done that. I basically, here's the client, here's the diagnosis. Here are the records that I reviewed to arrive at my opinion of what the cost will be in the future. And then behind that follows cost tables. This is just the total expenditure table where each area that is addressed based on this specific case are listed and the costs that I have come up with are listed. Then following that will be individual cost tables, really detailing everything that's in each of those tables. Table 1, medical evaluations, what type, how often, why do I say so? Well, because Dr. Smith said it's what he needs. Next page. One thing to remember in cost projections, there are no expert medical cost projectionists that you can call on as witnesses. We can be called upon to opine on the report that we have put together, but there's no MCP certification. There's no association specific to MCPs. There's no peer-reviewed universal criteria for who can prepare MCPs. Therefore, there are no experts. There are no defined experts. Next slide. However, if one would be questioned, well, how are you qualified to provide a medical cost projection? Well, I'm certified in a parallel field, life care planning. I have taken an educational course. There's only one MCP educational provider in the United States, and I have received that education. And so based on those two parallel areas, I am prepared to opine and testify. If it would ever go to trial, you know, they usually don't, they settle, but if I would need to be deposed on how I arrived at some numbers, that's how I would be qualified to do so. Next slide. Life care planning, and I'm going to go back and review these two, but get into life care planning. Again, we talked about the catastrophic injuries that are involved in preparing a life care plan. Going back to my point earlier, I sometimes will get a request, we will get a request for a cost projection, and I start to look at the records and it's like, oh no, there's too much going on here. There are a lot of changes. This really should be a life care plan. And then we go back to the attorney and say, have you considered doing a life care plan, and here's why. On the other hand, there have been a number of times when we've been asked to prepare a life care plan, and I look at the records and it's a very isolated injury. It might be a traumatic brain injury, but the patient has plateaued. There's no more therapy that can be offered to make them better. There's not a lot to produce for cost projections medically wise because they're plateaued. So we say, maybe look at a cost projection. This is, there may be some occasional therapy down the road. They're going to need follow up with this doctor for a long time, but there's not enough here to do a life care plan. So we do, that's one important issue to evaluate when you're looking at what you want to ask for. And clearly, if you're not sure, we can help you make that decision based on our experience. Next slide. Lately, the question has arisen, who do you want to prepare your life care plan, an MD or an RN? Probably in the past, let's say about 3 years, physician life care planners have really become more prominent in the life care planning arena. And I'm not here to say one is better than the other. I'm just here to say that as an RN, and this was touched upon earlier, actually by John, but RNs in our educational process are educated to address the entire patient, not just physical injuries, but to address them physically, emotionally, spiritually, and socially, as well as how this has affected their family. So from the get-go, that is just how we approach any of our clients, the whole picture. The MD life care planners, obviously extremely well educated, obviously know medicine better than anybody else. But the physician life care planners are specialized in an area of medicine. So a lot of them are PM&R, physical medicine and rehab physicians, obviously know rehab about an injury better than anybody. However, that physician cannot opine on other medical care related to this individual injury. They can only opine on their specialty. So they will still have to go out and get an orthopedic opinion, get a psychologist opinion, those types of things. So it's, gets back to, well, physician is more educated, they can do it all, but just remember to keep in mind that they also are very specifically credentialed, and that does limit what they can project medically for individuals. Next slide. One thing that is kind of drilled into the RN's beginning of education as a nurse life care planner is your job as a nurse in this life care planning arena is to return this client to as close to independent living as is possible. So know what it was, know how they could live independently, know how this has affected life, and are many of them or most of them going to be able to return to a normal lifestyle? Probably not. But we're going to get them as close as possible with as many assistive devices and therapies and assistants, caregivers that we can to make them as independent as possible. Next slide. As far as nurse life care planning experts, what qualifies us to be experts to testify? There is, as opposed to MCPs, there is a national certification for nurse life care planning, and it is the American Association of Nurse Life Care Planners. The American Nurses Association does recognize nurse life care planning as a subspecialty area of nursing. Therefore, nurse life care planners are experts in the field. They follow there is a methodology that is followed by all RN nurse life care planners. It's a methodology of nursing. So it's not a methodology that can be questioned, say they didn't use appropriate methodology, throw them out. No, it's based on the ANA methodology of assessing and caring for clients. Next page. So just as a brief comparison here, we talked about the medical cost projection being less complex injury cases. I didn't mention it is a lower cost option. It clearly does not cost as much for one to produce a medical cost projection as a life care plan. It is based on physician treatment plans and then anything that can be augmented by me with my nursing background. And it does forecast future medical costs, but in today's dollars. One thing I would like to point out is there is a wide range of outcomes for claim settlement. Just because they're less complex injury cases, yes, the over settlement values are lower, but they're not necessarily extremely low. They vary a lot depending on the injury that's being addressed. So specifically, I've had settlement at medical cost projection as low as $89,000 for an isolated knee injury, based on what the physician is projecting may go on medically or surgically in the future. I've had a cost projection that was $390,000 based on the injury. The patient was involved in an accident, and after all the physical injuries were healed, she had an ongoing seizure disorder that was never going to go away. And so the seizure medications alone were projected there for $219,000 over her life expectancy. And then I've also had the terminate, you see, $513,000 cervical spondylosis, degenerative disc disease, and some sternoclavicular joint issues that the treating physician said this client is going to need permanent pain management intervention. And so based on what he said those would be it steroid injections, ablations, whatever, the cost was $513,000. And the highest I've had so far was actually not too long ago. And it was a younger individual who had chronic pain from an injury and being seen regularly by a pain specialist. And the pain specialist was able to project over life expectancy, over this many years, I anticipate to give this many treatments. Then the following years, it should probably decrease to this, and the rest of his life probably really decrease to this. So I was able to take very specific physician information as far as a timetable and cost it out. And because of the youth, the youngness of the person who had been injured, the range went from $349,000 if he had good response right at the beginning. So this would be the shortest time frame that we could anticipate, or if he was having response but never full recovery, up to $961,000. So the ranges can be very wide, and I will present you with those ranges that you know exactly what you're getting into, as far as opposing counsel saying, well, what if? Well, what if? Well, we have the what ifs covered. This is what if he responds in the next 3 years and he's fine. This is what if he doesn't, and I have to continue to inject him over the next, 60 years. Next slide. Next slide. So just some real life examples to kind of tie this together for you. For instance, I did a life care plan on a double amputee, and prior to his injury, he was an avid fisherman and an avid hunter, and those were his special times with his son, his only child son. And so in addition to just saying, well, he needs prosthetic devices for ambulation, we also added he needs waterproof prosthetic devices for both legs because he needs to get back in the water to fish with his son. So we look at not just the physical injuries where he needs something to walk again. He needs to encompass his relationship with his son to be able to share those times. We look at all the avenues and add what's needed in that life care plan. One thing I wanted to just make you aware of, because I think it's in my knowledge or in my practice, this is something relatively new. But if you have a client who is saying, we need home care for our injured individual 24/7 for the rest of just 24 hours a day, 365 days a year for the rest of your life, because we can't we can't do this, we can't cope, we have to work, we can't whatever. A lot of people will think, wow, that's really going to drive up a settlement potential, because 24-hour day care at $24 an hour average adds up to a lot of money over a life expectancy of an individual. What some home care agencies are doing now, if you are requesting 24-hour care, they have a system, and I can't tell you financially how they work it because that's not my area of expertise, but I can tell you that around-the-clock care will be provided in 2 12-hour shifts for an individual at a monthly rate that is significantly decreased from a 24-hour a day hourly rate. So just keep that in the back of your mind. If the client can possibly just need somebody in the home for a shorter period of time, but maybe is willing to go to sleep, get them set, once they're settled by the caretaker and they're going to go to sleep, they're okay to be alone with them in the home, then your home care costs will be very high. But if you make it 24 hours a day, 365 a year, your home care costs is a very good chance will be significantly decreased. And just one final medical cost projection. We had, within the past 6 months or so, we had a case where the attorney came to us and he didn't tell us this at the beginning, but he told us this at the end. Opposing counsel was offering a $3,000 settlement for a case. And so he said, no, there's a lot going on here. Did get a medical cost projection, we did provide it, and he actually settled the case for $75,000. So the medical cost projections can have a lot of impact on your settlement. And of course, your life care plans, these are cases that nobody's questioning if there's going to be a settlement, but will be very extensive and very thorough based on nursing assessment. Next slide. I think that's it. Any questions? We can certainly address those later. Thank you.
Thank you, Jan. That was great. I just have a couple slides to do very quickly on bill reviews, if this is an issue for you. We've been approached a lot over the last, I'd say 3 to 5 years maybe, with trying to help attorneys understand the UCR and PIP fees and how they can use that when they're using private fee doctors to negotiate with the defense, because the defense doesn't want to pay the retail price, so to speak, that physicians can charge when they're doing private pay. So I just wanted to alert you to a couple things that we're seeing that are being caught by the defense. Inappropriate procedure codes in the bills, so they don't actually, the number doesn't match the diagnosis, and so they're trying to throw that out. Undercoding means that a provider has charged less than the UCR, so you can't recover the difference in the money there because you can't get more money than a provider has charged. Upcoding, you know, a doctor charges for a level 5 office visit, and you look at the medical record and the note was a very simple visit for 10 minutes for a single issue. So that is going to get caught if you have a careful defense attorney who's also bringing in a billing or coding expert to look at these bills, and these are going to be questioned. Another example is when you have a surgeon and an assistant surgeon both charging the same price for a back surgery. That's going to get caught all the time as upcoding, and that's going to be wanting to be corrected. And the same thing with bundling and unbundling. Services, the insurance companies and Medicare want to bundle services together so they could pay one rate for, for example, a surgery, an abdominal surgery where there are adhesions. They can't code for abdominal surgery and adhesion separately, because the abdominal surgery, the insurance will say, well, that includes a certain amount of adhesions. So when they see these billing errors, this is what the defense is looking for, and this is what they're going to come to you to try to knock out. And then, of course, I forgot to put this on here, but just making sure that you're only including bills for services related. So if somebody goes to the emergency room for an asthma attack, and that asthma attack is not related to your auto case, that's going to get kicked out. So those fees are not related to the incident at hand. Thought I had a typical report. I don't know what happened to that slide. I apologize, but we'll look at on the bill review, we'll look at what are the CPT codes, what are the charges by the provider, then what should the PIP fee be, and what should the UCR be, so that you know the floor that the defense attorney is probably coming in on, and then how you stack up each fee based on that. Medicare set-asides, we also have nurse certified set-aside providers who can submit to Medicare if you are talking about a workers' comp case. And we've had a few personal injury cases where the defense wanted to see an MSA, and the plaintiff attorney wanted to proof the defense attorney's MSA, similarly to the defense attorney who does a critique of the plaintiff's life care plan. So if you're ever in a need to look at those economics and making sure that Medicare is protected, we can help you with that. And then lastly, when you have a client who is being denied treatment, we've had a couple of times that we've been asked to have our appeals expert work with the treating provider to try to get the patient's care approved through their insurance provider. So we do have appeals experts that can help you with that. And then similarly, if you're in a class action, our appeal and your client hasn't been put in the right category, and you think that they should be at a higher level of injury, then we can help you go through the medical record and pull out supporting documents. So those are really an overview for you on the various damages, and I'm going to just stop my screen and take us back. Those are really an overview for you of damages, how we try to take the hidden injuries and make them more visible and maximize the value of your case. And I think we have a few minutes for some questions, and we'd be happy to answer them. Thanks so much for joining us today.
Yeah, this was terrific, Mindy. I've been getting so much good feedback. We did have a question that came in from Dr. Pettingill. And for those of you who do not know him, he's actually a great economist out of Florida. So anyway, he'd like to know, how do you compute the lifetime cost?
Good question. So there are a few states that have specific tables that they want to be used. For example, North Carolina, they don't use the cost tables given out by the federal government. But most times, my reference here, we generally, unless it is preempted by a state requirement, I use the federal government guidelines of the life tables for males and females, and the most recently updated ones. And so they specifically, you look at the age of the client, and it gives you the life expectancy. So it's based on that government data. Does that answer your question? And plus the cost that I give in either a cost projection. Can you hear me? Okay, in a cost projection or in a life care plan, they are in today's dollars. So we do not forecast. That is up to you, the economist, to do that. We only do it in today's dollars, and then the attorney needs to go to the economist to project future, what that translates into in the future.
Okay, great. Thank you so much, Jan. And what I want to do is give everybody a few more minutes. So if you have any questions, now's the time to get them in to the Q&A box. So while we are waiting for some of those to come in, I'm going to go ahead and bring in Kyle Kinberger again from HMR, so that way he can do the announcement of the winner of the 4 bags of freshly roasted coffee. And you guys, this is a delicious, wonderful prize. So I cannot wait to see who wins. And don't worry, if you don't win today, you have a chance to win tomorrow, because we just added like a brand new webinar yesterday. And actually, it's going to be tomorrow. It's going to be really interesting. It's going to be at 3 o'clock Eastern time. It's going to be on cell phone forensics for legal professionals. And basically, we've brought in an expert. His name is Lars Daniels. And it's really cool. He's going to be talking about cases that he has done where he's been able to get the evidence from cell phones and literally it's incredible the stuff that they can find. I'm sure you guys know when you get into a courtroom and you're about to do a case and you have somebody up on the stand and they're saying one thing, whereas Lars comes in and he finds out the actual truth. Now, can you imagine being in the hot seat? I know I wouldn't want to be. So he's going to talk about some really interesting stuff. I would sign up not only because you're going to learn something new, but because it's going to be pretty entertaining, I think. And then, of course, on Thursday, you don't want to miss Thursday. That is our 100th webinar that we have done since April of last year. It's amazing. We have some really great speakers. Doug Bean's going to be joining us with Richard Shapiro and Catfish Abbott out of Florida. We've got a lot of prizes in store. In fact, Kyle will be joining us again because he's going to be giving $100 worth of this coffee away. And that's a lot of coffee, but we're really excited about it, Kyle.
We're just trying to keep everybody awake. I'm like the entire time, so it's all good.
We're gonna have some fun on Thursday. So do the honors. Please let us know who's the winner of today's coffee giveaway.
You got it. So today is Lamar Alejo from Orlando, Florida, with the Alejo Law Firm. So congratulations.
Hey, congratulations, Lamar. He's so lucky. Oh my gosh, he's going to enjoy this. Yeah. All I know is we can't thank you enough, Kyle, for doing such a wonderful giveaway for our attendees. We've had a lot of fun with this, and who doesn't love coffee, right? So
I'm like, unfortunately, I have to have it every morning to get going. So
exactly. Well, thank you again for all that you do. And if anyone has any questions for Kyle, be sure to reach out to him anytime. He's always there. And I'm going to be sharing everybody's contact information. In fact, I'll go ahead and do that right now for you. I definitely encourage you guys to reach out to Mindy, to Jan. They're just so wonderful when it comes to understanding this type of work. They've got such great knowledge. So I will make sure that you get a copy of this in just a few minutes. I'll email it to everybody. But please keep them as a great resource that you can use now or later on down the road. But thank you so much to Jan and Mindy for speaking today. And again, to all of our incredible sponsors like HMR and Fast Funds, Strategic. Mindy, I did want to ask you, do you want to talk a little bit about OnPoint? Because you guys are also just a wonderful partner of ours, and you do such great work. You did this wonderful webinar for us, but is there anything you want people to know about OnPoint?
Oh, thanks, Ginger. Yes, I would love to. Always love to talk about OnPoint. I mean, in addition to everything related to the damages component, we actually can be involved in your case from very early on. Medical record review, merit screens, locating experts, liability, causation, and damages. We have an exciting nursing home division, which covers everything on the long-term care spectrum, from independent living, group homes, assisted living, subacute rehab, and nursing home. And so we have a great review of experts, nursing home administrators, wound certified specialists. We have a geriatric clinical nurse specialist who coordinates that program. So she's a tremendous resource to attorneys on getting those cases up and going. We attend defense medical exams. We do medical research. So anything, we're sort of a one-stop shop when it comes to helping you understand the medical records. Our goal is to make sure that the attorneys are the most prepared in any room that they're in, and they really understand what's in the record and how it helps them and what challenges they might need to overcome to present their case in the best light. And I'm really excited about some new things that we have coming down the pike of record retrieval and organizing medical records, and really coming from the very beginning all the way through to the very end of testifying at the case. So we're going to roll that out. It's going to take a little bit of time, but we're real excited to be integrating that into our line of services. And as John said, of course, like interviewing clients, we can interview, we can look at your intake memorandum and just speak with the attorneys directly about what follow-up questions might be important to ask. What are the key medical records? Do you have the right chronology? Did the plaintiff give you the right information to track their story? So there's a lot from our nursing background that we're building into our services, and we're really excited about that.
That is fantastic. Thank you so much for sharing a little bit more information with us, because it's amazing the different types of things that you guys can offer. Like you said, you can call Mindy and ask her a couple questions. Another thing that I just wanted to point out is for any of the paralegals that are watching, this is a great opportunity to call Mindy and have them help you take off some of the workload that you have so you can focus on other things. So especially with those chronologies as well.
Yeah.
But
easy to work with in that regard. We're not a hard sell, and you might need us on some cases to do a lot of heavy lifting, and then you might just need a quick phone call to point you in a direction for something else. So we can come in and out of a case and in and out of your life sort of as you need it. I mean, we've gotten calls from an attorney that said, I just got out of a deposition and my expert just testified that he's got 2 felonies and I need to replace him in 2 days. So call us, we can help you with that. Or you could call us in the beginning and I'm really not sure, do I need a neonatologist or a pediatrician for this case? Can you talk me through the issues and we'll talk about it. So we're really flexible and we're here to help.
Wonderful. Thank you, Mindy. And before we end, I know Jan, I think you had a couple more points that you wanted to make?
Well, just a little bit in line of what Mindy was saying. The reports that we provide, the cost projections and the life care plans, specifically the cost projections, because I see a lot that don't have this. Everything is based on fact. There's never my opinion as a nurse, this is what's going to be. Everything is backed up with facts, and they're listed on the cost tables. Where I found that information, did I use what CPT codes were used? Was official disability guidelines can be used in some cases where the doctor hasn't given real specific length of therapies. A lot of substantive research is provided to back up a timetable, whatever is used. So these are all fact-based. There is no opinion-based that opposing counsel could break down and say, well, this is an opinion. No, everything is backed by facts.
Okay, great. Thank you so much, Jan. And so now I just want to thank everybody again so much for watching. Please join us again tomorrow and definitely on Thursday. But Mindy and Jan, thank you so much again for speaking today. Thanks to all of our sponsors and thanks to everybody watching for all of your support. We hope you have a wonderful rest of your day. Stay tuned for my email in just a few minutes. And thank you again for watching. Bye, everybody.